So this is just a visual representation of that, which I'm sure you can't entirely see, but it makes the point that, again, looking at the level and the kind of target, the nearness of the target that you're also trying to intervene in, that helps and is important for operationalizing. Do we want to affect something very proximal around risk behavior or even infection? Or are we interested in affecting some of the larger social arrangements that we can confer vulnerability and eventually translate to HIV infection, like not having stable housing or having economic inequalities that don't allow for access to health care? So what is it that one is really trying to address, and at what level, through the individual or through a more social level approach? So going from the operationalization, once we get clear about what it is we're trying to do and what we mean by a social driver or factor and which one we're trying to address, then the question is, how do we do this? How do we set this up in a research and a rigorous kind of study way? And here is where the methodologies kind of get in our way, or we have some difficulty around methodological issues. And this is a large discussion that many people in this room have been engaged in and written a lot about. That has to do with whose methods count and why, a sort of sociology of knowledge question, which I think is fair game. But it puts us in the position as social researchers as often being in opposition to the mainstream kind of hegemonic mode of biomedical or medical research, which is randomized controlled trials, gold standard of evidence. And historically, our field has been dominated by those sciences that can do those, the behavioral interventions that are mostly health psychologists who have designed these interventions and can test them in randomized trials, or the biomedical technologies. And we're not really in opposition. I think it's important to say that, but the point is there are some strengths to doing randomized trials when they're appropriate, but there are also some limitations that we have to keep pointing out and reminding, particularly when we're looking at the social level, like the low generalizability and external validity of this kind of methodology. It's also the case, and I certainly know this is true in the United States, that the focus on that kind of methodology for assessing everything and its efficacy has really hindered the introduction of innovative research questions. What happens in the US and probably elsewhere is you start with what can we do in a randomized controlled trial to address, adolescents in New Jersey, instead of saying, what do adolescents in New Jersey need? Or what are they about? And then what's the kind of studies we should be doing? And that happens consistently. So there are a lot of different kinds of approaches and methods that can be used in social research. Again, I'm sure you're familiar with most of these. And the point is really let the question drive the method, not the other way around. And this slide here just gives some examples of, depending on what it is you're trying to do in a study, the relevant methodology is obtainable. So the key points here from this trajectory, from the conceptualization, operationalization, the methods, and ultimately evaluation of social level approaches and responses, is that we have to engage these underlying factors if we're going to combat HIV. We have to accept that it's complex to try to draw and to be able to draw causal linkages between social drivers and determinants and HIV. The importance of local context cannot be overstated, and that we may have to be willing to engage in some more non-traditional or non-hegemonic methods that are derived from sociological plausibility and that draw on extant epidemiologic as well as social research. So that's kind of a quick run-through of what we try to convey in that paper and what generally is sort of my spiel on this subject. And that we kind of outline some steps just to be very clear about how one can go about engaging in a social level approach, starting with an assessment of the social factors. You can't just sort of assume you know what's going on in any community unless you're indigenous to it. But looking at what are the risk and vulnerability associated factors in a particular place or people, hypothesizing, and hypotheses are very important. What are the sociologically plausible chains that lead eventually to HIV risk or resiliency? Figuring out what can you influence and what can you not influence, and being very explicit about assumptions about how these social influences work, and then being really rigorous and building in evaluation mechanisms. So those are key steps. So that's sort of the science frame, the combination prevention, the need to really build up the social piece of the combination prevention strategy and provide rigorous research-based approaches that can be usable in real community settings that address social level factors. The other frames that I think all that science is operating, it's important to identify that science itself is not happening in a vacuum. It's happening in context, as I mentioned. And a frame that is particularly relevant now in the United States, but I think is at least part of, it has some relevance in Canada, is a version of a national AIDS strategy or plan or framework. And I'm choosing my words carefully because it's my understanding, and I've asked a few of you, I'm a little confused about whether you actually have a national strategy or not, and I understand you are too. So, so there is the Leading Together, and there's the federal initiative, and I'll mention that in a minute. So I'm taking that as your version of a national strategy, even though I know it's not exactly the national strategy in the same way as our new national HIV/AIDS strategy is. Because ours, which is the first the United States has ever had, believe it or not, comprehensive national AIDS strategy, is driven by and owned by the federal government, and particularly the White House. This is the President of the United States who introduced this strategy and really owns it and will be accountable for it. So I think that's a little different from the Leading Together and even the federal initiative here. But I don't want to get into what these strategies are as strategies. It's much more as a frame in which we should be thinking about social research. So what's interesting, and I'm using the Leading Together document because that's the most fleshed out version of a framework. I think that was operative, and I'm not even sure if it still is because it was supposed to end in 2010, so you can tell me what the current state is. But the point I wanted to make is that each, the Canadian version and the US version, have a vision that sort of introduces why we are doing what we are doing or what we should be doing to respond to HIV. And the visions are somewhat similar. So I have a feeling that the US folks looked at yours, to tell you the truth, but that's another story. So the point, there's your vision, and here's ours. It's a little more pithy. But this is a statement. The United States will become a place where new HIV infections are rare, and when they do occur, every person, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic circumstance, will have unfettered access to high-quality, life-extending care free from stigma and discrimination. You would never have heard that in the most recent past regimes. This is a pretty profound statement for the United States to even have words like sexual orientation and gender identity and unfettered access while they're busily dismantling healthcare reform, which you all probably find amusing more than anything. It's really disheartening. So we have these visions of the world in which we hope to live and that the plans and the frameworks should actually get us to. I looked at the federal initiative and, again, trying to ascertain which one is really the operative plan or strategy here. And I guess their point was to say we work in concert and we encourage everyone to think of the Leading Together as the national framework and identified 4 goals, which are pretty much what appears in the Leading Together and the U.S. National AIDS Strategy. So here again, my comparative point here is to say that both plans have a vision. They have goals that are very close to each other: reducing new infections, ensuring access to care, and better health outcomes, which is less stated in the Leading Together but is in the federal initiative. And some version of reducing inequalities and disparities, which is the word we tend to use in the States, that have to do with race, sex, class, ethnicity, and geographic location. And then we have the ever-present need to improve our cross-agency collaboration. But that's actually the stated goal in our plan. So looking, and I'm just going to run through these quickly in the interest of time, but there's a prevention goal that has targets. So each of the goals has some version of targets. In the U.S. plan, they're much more specific, and that was part of what we wanted to make sure happened in our strategy. So by such and such a date, we are going to affect such and such a change. And in this case, reducing infections by a certain amount by a certain year. You have something sort of close. Here's the care and support and treatment goal targets. Again, somewhat similar with slightly different focuses about identifying infections, linking people to HIV care and general care, and We have some programmatic specific things. That's what the Ryan White refers to. But ensuring continuous care and better health outcomes for people living with HIV. And we both talk about housing as very important because there's now a great deal of data supporting housing as an important aspect of improving the health and well-being of people at risk and living with HIV. And then the inequities, disparities goals that each strategy framework plan has are also somewhat similar, although ours get very specific about diagnosis and making sure that because we have so many people who we believe are living with HIV who do not know they have HIV infection, anywhere between 20 to 25%, but the rates may be higher in certain populations defined by ethnicity or geographic location. So the goals have to do with addressing that in particular as a way to get at the disparities in care and health outcomes. Now, the Leading Together document has something we don't have in our strategy, which is an explicit mention of research and the role of research in the strategy or the framework, and that's really nice to see. You know, to get ahead of the epidemic, we need research, and this document talks about the range of kinds of research, including psychosocial and social research, and what research is really essential to help us do. In the U.S., we didn't have an explicit goal around research, and so what we did was, we being a number of advocates who were behind the whole development of the National AIDS Strategy, brought together a number of researchers in an external consultation and said, you know, help us define what ought to be the approach and the priorities for research as it relates to the national strategy, and then we fed those recommendations to the White House. So research is there, but it's kind of underlying our strategy without explicitly being mentioned in the main document. The operational plans that our federal agencies have now developed do obviously involve the NIH, and a lot is said about research there. But it was interesting what this interdisciplinary group came up with, and I don't want to bore you with all the outputs of the meeting, but just to say that they made some, you know, general points as you would expect about the general role of research, but were explicit, and this was a lot of HIV docs, not necessarily social scientists. It was very interdisciplinary, but really brought a lot of attention again to the importance of social research and combination approaches, and the importance of maintaining support for basic research. So a lot of people now argue that we should only do research that is clearly got an applied aim towards it, that can be applied, and we know how it can be applied. So intervention kind of research. Other people will argue, no, we still need to do a lot more basic research. And whether that's immunology and virology or social and behavioral science, the basic research is still, I think, important. We also had the NIH, the National Institutes of Health, also convened some folks after the National AIDS Strategy was introduced to say, help us figure out what we should be doing in the specific area of social and behavioral research as it relates to the goals of the national strategy. So we have a much more, the strategy has become a frame by which we can prioritize research much better. So there was a group of folks, about 100. I was co-chair of this group, external co-chair with Tom Coates, who you may know of. And that group came up with a vision for research, that in order for the national strategy's goals to be realized, we have to have a coordinated response for research as well, and that integrates everything from case finding and diagnosis to social and behavioral prevention, as well as community involvement and respect for human rights. So that was a pretty strong statement from a bunch of researchers. And of course, a robust social and behavioral research portfolio from discovery, meaning basic social research, to implementation is essential. A lot of this is code, again, because there's been so much pressure and emphasis on interventions research, and that tends to be what gets through the review panels at the NIH, and folks have really been arguing for more basic research. Here are some of the areas that group thought should be emphasized in this moment to sort of move the field from a lot of the stuff we've been doing over and over again, getting at things we've already been talking about this morning: complex models, transdisciplinary theory building, even doing more research on social processes and social change. So a lot of federal agencies are not real keen on funding research on social change because the targets of that social change are often them. But people feel that's obviously very important research.